Good evening, everyone, and welcome to tonight's session. This is our 16th PD in Your Pocket in the PD Pocket series from New South Wales Family Daycare Association. And we are really happy to have you this evening. My name's Elizabeth. I am your facilitator for this evening. It's been a little while since I've joined you for PD in Pocket, so I'm really excited to be here with you tonight. Before we begin, I'd like to acknowledge the traditional owners of the country on which we meet today. I know we're on many different lands with many different traditional owners, but New South Wales Family Daycare Association is presenting this webinar from Gadigal country. And it's important that we remember that Aboriginal families have managed their children's medical needs on this land for thousands of years. Despite the Aboriginal and Torres Strait Islander people experiencing more health disadvantages than other Australians, these disadvantages can include high rates of illness and shorter life expectancy. So I'd really like to pay our respects to all Indigenous people, including those present this evening. Okay, so I'd like to check in that everyone has received their resource booklet. So we sent you a link to a specially prepared booklet last week. If you didn't receive it, you can find the link on the screen if you are watching this presentation, or if you're listening as a podcast, the link is www.nswfdc.org.au/PD in your pocket. And I'm pleased to let you know that the New South Wales Department of Education will be funding the next 4 sessions of PD in Your Pocket. So we're really grateful for that. We have been asking also, some of you have been asking why, when you register, only some family daycare service names are on the sign-in. So all New South Wales services are in there. If you come from another state, you can just select other. So currently we're just needing to collect data from New South Wales services. We will also be sending you surveys after the next 4 sessions. So we'd like to ask you, please fill in the survey, because this helps us to get the funding we need to continue to provide such great training and also for free of charge. So really valuable for you to fill in those surveys if you can do so after each session. Okay, now before we get into tonight's content, I really want to revisit when you registered for this session, we asked you some questions, and I'd like to share what we learned from you from those questions. So the first one was, we asked you if you currently have a child in care with a specified medical condition. So 30% of you said that you do, and 70% of you said you don't. And we were really a bit surprised by these figures and suspect that some of you may have been counting children with a disability as having a medical condition. So we'll go through the difference between a disability and a medical condition shortly. Next, we asked, are you confident that you know exactly what to do if someone is exposed to an allergen or has an asthma attack or goes into a diabetic coma? Now, 33% of you said yes, absolutely. 47% of you said yes, mostly. 15% said not really. 4% said, and 1% said not at all. So these answers are a bit concerning. Now, every family daycare educator should be doing regular first aid, anaphylaxis, and asthma management training. So to have 20% of educators who think they would not really know what to do or understand what to do if there was an anaphylaxis or asthma or diabetic emergency is a bit of a problem. So if you were in that percentage group, make sure that the next first aid course you enroll in is a good one, and speak up if you don't understand anything. So make sure you ask questions so that you've got all the knowledge you need to respond to that. Okay, the next question we asked is, have you ever had to deal with a medical condition emergency at your family daycare? So 19% of you said yes, 79% said no, and 2% said not sure. So that's about 1 in every 5 educators that has had a medical emergency at their family daycare. So that gives you an idea. Next, we asked, how well do you know your services managing medical conditions policy? Now, 42% said very well, 51% said well, 7% said not very well, and 0.5% said not at all. So just a reminder that it is an obligation of every educator to know, understand, and implement your services policies. So that 7 or 8% have some upskilling to do. All right. Well, thank you everyone for taking the time to answer those registration questions. It's really great information to go over together, and it gives us an idea of where everyone's sitting in terms of their knowledge and their experiences as family daycare educators. So thank you for answering those. Okay, what are we going to be covering tonight? So really good session tonight, all around managing medical conditions. We're going to look at what a medical condition is. We're going to look at the difference between a medical condition and a disability. We'll look at why we need to be equipped to deal with medical conditions, how we prepare as an educator to deal with medical conditions. We're going to look a bit at allergies and anaphylaxis, which we know are very important, that we know how to respond and manage those. We've got some great videos with educators. We've got a total of 3 videos tonight, which I'm excited to share with you. And then, as always, we'll have plenty of time after the session for questions. All right, so let's get started. So let's understand, first of all, what are medical conditions? So a medical condition, it consistently requires medical treatment and supervision for a continuous period. And it's a result in restriction to the child's normal activities. So it results in them being restricted in what they can do. And it requires significant levels of personal care by the family. Now, common ones that you may be familiar with include diabetes, asthma, and anaphylaxis. If a parent alerts a service on an enrolment plan or an enrolment form that their child has a medical condition, or alerts their educators that they have been diagnosed with a medical condition, the service you are registered with must take certain actions. Now, children's medical issues and management must be discussed with families, including the provision of a medical management plan, which we'll look at later, and supporting documentation if required. So in collaboration with family and carers, the service must develop a risk minimisation plan and a communication plan if an enrolled child has a specific healthcare need, an allergy, or relevant medical condition to minimise risk by ensuring educators understand the medical conditions policy and each child's medical requirements. So, what is the difference between disabilities and medical conditions? Now, sometimes we enroll children with additional needs in our services, and these include children with disabilities. Examples of disabilities can include autism, acquired brain injury, cerebral palsy, and these things may require special inclusion support to enable you to include them in your family daycare effectively, but they are not considered medical conditions. So you're not necessarily going to monitor the health of children with disabilities or administer medication or ensure the child with a disability does not come into contact with an allergen. So you do not have to have a medical management plan for a child with a disability. Some children with disabilities may also have medical conditions, but not all children with a disability do. Now we're going to do something a bit different, and I'm going to show you one of the 3 videos you'll be watching now, because it includes a discussion about the difference between a medical condition and a disability. So I'm going to play that for you now, and then we'll have a chat.
to have Kylie Purdie with me. Welcome, Kylie, to
Hello.
PD in Your Pocket. Tell me a bit about yourself as an educator.
So I've been a family daycare educator now for almost about 5 years. I have been in education and care for 30. This is my 30th year in education and care, in a huge variety of roles.
Started very young.
19, not too young, but anyway. But it was, so I've been in a variety of roles after school care. I've been a director, I've been a trainer, and interestingly, in line with our topic today, I found myself in family daycare because my son, who was 15 at the time, has a chronic medical condition that appeared at about that time, and I just needed to be home. So that's what led me to family daycare, but I love it. It's been, so the last 5 years I've been family daycare educator, and it's been one of the best decisions I ever made.
That's great. So what sort of medical conditions have you had to deal with during your time as an educator, either in centre-based care or
so quite a few. It was actually when you posted it on the Facebook page, I was trying to think, and there's a lot of ones that I don't really specifically remember. Obviously, asthma is a very common one, so we've dealt with a lot of asthma. I did have a child with congenital heart disease, which was an interesting challenge to have because she had so many medical needs attached to that. We also had a child, and I can't remember the exact medical condition it was, but she couldn't retain couldn't retain calories and things like that. So she constantly had to be fed. So we always, right up until, every hour we had to be making sure that she ate or that she fed, and then she had a tube for a while as well. So that was also a bit of a challenge attached to that. So I guess that's been the most. We've had children with anaphylaxis, which luckily didn't need much in the way of management, in that we never had it to deal with not an outbreak, that's the wrong word.
Anaphylactic attack.
Yeah, that's it. But we always had to manage it in our service in terms of being aware the whole time. So I guess that's the most.
Kylie, have you ever had to deal with a medical emergency?
Medical emergency, yes. So we've had to call an ambulance for an asthma attack. That was quite.
Is this in centre-based or family?
Yeah, so that was in centre-based. I haven't had to as a family daycare educator. I've been pretty lucky so far in that anything that we have had, we had hasn't needed to do that, and that we've been able to manage it. But in a centre-based care, we had a child that used their reliever. We followed the asthma management plan, and after a number of times, her breathing did not settle, and in communication with the mum the whole time, because she was at work, which was, was making her way to us, but it was quite a length of time, and she just said, call the ambulance. So we did. So, and then she went.
Was the child okay?
Yeah, the child was fine. They went to hospital. I don't even think they ended up staying overnight. I think they ended up going and having treatment there and then. And I've done that with my own child, so I know what that's like. But it definitely can be adrenaline inducing as staff. I have had incidences which aren't from a medical condition that a child has had, but we've also had to call an ambulance for serious injuries as well. So that's just as adrenaline causing as well. But you just do it. You just act. That's where having good management plans.
That one of the advantages of family daycare is often educators and the parents live and work in a small kind of location, so it's
absolutely. I know the children that I've had that have had asthma. So we had one probably 2 years ago. The child had developed, so she had a very nasty case of bronchitis, and it turned into pneumonia or almost, and then from that time on she has needed Ventolin, needed asthma management plan, and needed that in place. But I found definitely the moving from centre-based, both long day care and after school care, and into family daycare, you definitely work much more one-on-one with the families, which I really like. It's easier to. In a centre-based I have nothing against centre-based care, but I find there's always a new educator or there's always someone new in the room, and you're handing over to someone and you're always, okay, this child you have to be really aware of, this is the management plan, this is this. But with family daycare, you're just constantly in that communication. So you're the person that's there to drop off, you're the person that's there for pick up, you're the person at the other end of the phone. I find that was a lot less stress inducing, I suppose, dealing with that and supporting families in that way. So yeah.
Okay. Now, one of the things that you and I both commented on in the Facebook group, because we saw it happening, was when I did a call out for people and said, who's dealing with children with medical conditions, a lot of people wrote that they were, when in fact it was disabilities.
Yeah.
So can you talk to us a bit about the difference between disabilities and...
I guess it's tricky for me personally, and we're affected by this in my own family. So my children are adults now, but I have a child who's autistic. So he definitely has lots of challenges and things that we've had to deal with and things that we've had to work with. But he doesn't have a medical condition. So he doesn't need medical support. He doesn't need ongoing medical support. He doesn't need medical intervention. He hasn't ended up in hospital for medical reasons. He's autistic and he needs support, absolutely, but we're not talking about medical support there. I have another child, he's 20, and he has what is called autoimmune hepatitis, which is a significant medical condition, one that needs medication every single day, one that he needs blood tests every 3 months. We need to be keeping an eye and make sure that he's not going jaundice. He has a whole complex medical intervention that is required. So in my layman's terms, not having any medical treatment, that real distinction between needing medical intervention or regular medical intervention, whether it's medication or doctor's visits or that sort of thing, is vastly different to someone that might just need support or inclusion, which means that we need to make our environment help support those children rather than, So for me, I see that. So
I think that's kind of how I distinguish it too. I've also got a child with a disability, and the way that I've learned to do it is the disability is the impact possibly of her medical condition on her life.
Yeah.
So how the medical condition that she had has impacted her life on an ongoing basis. Yeah. Whereas she also has a medical condition, which is epilepsy. Yeah. And so needs treatment for that. And so if she was to go into care, she wouldn't, because she's 30 years old, much older than that. But if she was to go into family daycare, she would need an epilepsy management plan to deal with her epilepsy. But her acquired brain injury, which is her disability, she wouldn't need a plan for that.
Yeah, I've had children. So I worked in an after-school care program where we had a significant number of children that came from one of the local inclusion schools, or special needs schools as it was called. And one of those children specifically, he was autistic, but he also had anaphylaxis to a variety of foods. Not some unusual ones as well, things like apples and things like that. It was a bit odd. But we had two distinct plans. So we had his autism support plan, which was very different, and that was what we did that, but that wasn't a medical plan. The medical plan we had in place was for his anaphylaxis. So that they're two separate things, and just because someone has one doesn't mean they have the other. So I guess sometimes, and it's you can then start talking about the medical model of disability as opposed to the social model of disability, which is going to be way too big a topic to cover in this little bit. But I think that's where we are. I think we still are very focused on the medical model of disability as opposed to the social model. So I tend to lean towards the social model. So I like to distinguish between what is the medical.
I think that for some educators, and like I'm certainly not judging anyone that wrote down a disability in that thing, but I think it's like what they think of as, these are the children that we've got to do some extra stuff with in the planning, in the whatever. But I think it really is important to think in your head about that distinction of, do I need an inclusion support plan for this child, or do I need a medical management plan?
Yeah, I think
and a
they're two
risk
different things.
assessment?
Yeah.
Yep.
With medical support plans, you engage with doctors, or doctors' plans. Especially an asthma plan is really easy to look at. That you get a asthma management plan from the doctor, and it gives you what medication you're going to take, how often you're going to take that, what might lead to that, and if it doesn't happen, what we need to do in terms of, do we call an ambulance, do we call the parents, do we call all of those things. So there's a very specific medical situation there. When we've had a child that needed other medication given, we get training and support as to how do we need to give this medication to this child. It's very individualized, and I mean, it's individualized for all the children, but I don't know, I guess it just has a different, to me, you should be coming from it from a different side, I think.
For sure. Okay, can I just talk to you for a minute about anaphylaxis and the difference between anaphylaxis and food intolerances or food allergies? Because I think it's also one of those things that, parents are prepared to say, yes, my child is, allergic to X or Y. And then you ask, if they've got an EpiPen, etc., and it's not really anaphylaxis. It's not even necessarily sometimes even medically diagnosed.
No, and I've been a very big, that's actually something that comes across very often, that parents will say, oh, they're allergic to, and I'm like, well, can I have some more information about that? And I've learned over the years to be really persistent with that. I'm like, no, actually, I need some more information. I need some more clarification. We had a situation in one of the after school cares I was at where the parent had said that they were allergic to fish. And I didn't get that. One of the other staff members did the intake, got all the information and all of that. And it was for a school holiday program that I wasn't specifically going to be involved in. So I wasn't really engaged in it. And then I ended up working the school holidays program, and they said, oh, yeah, this child's allergic to fish. And I used to always have tuna in my lunchbox. That's what I always took. And they said, oh, no, you can't eat that here. And I was like, are you sure? So let me, and anyway, I clarified with the parent later, and they said, oh, no, tuna's fine. Any canned fish is fine. It's just, white fish. You can't have, fresh white fish. I was like, okay, cool. We're not going to have that. So that was a really important thing to clarify with family members. Do you need that? Lactose intolerance is another one. Quite often people can have cooked lactose, they can have cooked cheese and melted cheese and things like that. So it's not actually an anaphylaxis thing, it's an intolerance or a preference even sometimes. And I think we need to be really, really clear. If ever a parent says, my child has an allergy, is that, okay, do they have an allergy plan? Do you have an anaphylaxis plan from your doctor? Do you have anaphylaxis pen, an EpiPen? Do you have a treatment, what you're going to do? Do you have specific foods that you want to avoid? Sometimes it's even down to brands and things like that. They might be allergic to one specific type of, like corn flour. Some corn flour is made out of corn, some corn flour is made out of wheat. So you can't just say, oh, they can't have corn flour, because it's really dependent. So really, really getting detail. Don't just take it by rote. Just say, okay, I need lots more detail about this, because it could be as simple as. And I've had parents that come back to me months later, because I go up to them and said, oh, I'm really sorry, they've had some dairy. And I said, oh, yeah, we've been giving them dairy for months. Sorry, we didn't let you know. And you're like, oh, thanks. So, yeah, that's the other thing, is to really be always checking back.
I think it's also important with anaphylaxis to remember that not every child that might be subject to anaphylaxis has an EpiPen.
No, yeah, they don't.
I've got a close friend that has anaphylaxis, but he can be managed just with,
antihistamines. Yeah,
as long as you apply quickly.
Yeah. I've had another friend like that. She was allergic to anaphylactic to nuts, not peanuts, other nuts, and she just needed an antihistamine. That was generally it. So yeah, it's not all just necessarily that you're going to need it.
And I think that's
everything.
the sort of thing that you need to work out in your risk management plan. Can I just ask, with risk management plans, how do you go about drawing them up?
Well, our service particularly has preferred formats, basically, for starters. So making sure we have that. But I try and gather as much data as possible. So I'm always saying to the families, okay, you need, give me as much detail as you can for something like that. So when it's something to do with medical reasons, it's like, okay, give me every worst case scenario you have or in your mind so I can have an idea of what it is. I also look at my own home. So, for example, in my home, I actually say to families, this is not a nut-free house. It's not nut. My autistic son, nuts are his main form of protein, so it cannot be it cannot be a nut-free home. So we have those conversations. So we gather as much information as possible and have a look at that. So is nuts going to be a problem in my house? There is a risk. We have Nutella, we have peanut butter, we have that sort of thing. Do I serve it to the children? No. So family, that would be something in my risk management plan that I would put down if that was something that I would come in. So it'd be gathering as much information, sharing my information.
So how would you manage that particular risk?
With that situation, honestly, I suspect a family would not then use my services. Honestly, I think that they would. But in saying that, my own son, the same son, when he was in preschool, he actually went to a preschool where they had a child who was anaphylactic to nuts, but the preschool was amazing and actually supported us knowing that nuts were his main form of protein. At the time, he was diagnosed with ADHD, not autism. And we knew that good doses of protein for us, we knew that that supported him and to be able to help to stay attentive throughout the day. Like any children, really, you give them good sources of protein, that's what happens. And they had a whole big process, and they talked to both us and the other parent, and they served him on one table on one side of the room, and they make sure that the other child sat on the other side. They had a special bucket that had all the cleanup for my son's things. So they put those things all in place. And there was a discussion.
Sounds like an amazing service.
Oh, honestly, it was one of my most favourite preschools actually when I was in Adelaide, when I lived in Adelaide. And they put families first, and all families. And that's not to say they put others at risk. It was definitely a conversation. And I would never have said, if that family was unhappy, I would never have pushed it. But they sort of said, oh, no, leave it with us. We're going to see if we can come up with a plan. And they did, and it worked. And as far as I know, there was never any issues. So there's always ways to manage risk, I think. And if it becomes too much, well, then either that's not a match, and that's okay. So if the service isn't a match for the family, then that's okay. I think that's the other thing we need to remember, is that it's okay that sometimes it doesn't match.
For sure.
Yeah.
So what's the best advice you'd give to an educator that, is on the verge of enrolling someone with a medical condition?
Families are your absolute best resource. And I think sometimes we like to, I was actually making a few notes after we spoke yesterday, and I was just thinking about it. And I know that the families and parents are not medical practitioners, and sometimes they have, this works. I know it's not what they require, but they're still your best resource. They know their children, they know what works, they know what doesn't. We then making sure that we ask lots of questions. If you're a little bit uncomfortable, you ask. Having a child who's medically complex, which like I do, ask questions, and no one's going to be offended. A parent is not going to be offended if you are asking lots of questions. So if you're concerned, you go down. The other one is to be careful of black and white rules. So we haven't mentioned it, but it's actually when I put the medical condition up. So my eldest son has a medical condition called juvenile recurrent parotitis. So it is a recurrent swelling of the parotid gland. So he's had mumps about 40 times. So it's bacterial, it's not viral, but it causes a huge amount of pain and it causes a fever. Management is paracetamol or ibuprofen, either one. And he takes it, and he took it at the service, he took it at school, he took it at everything. And a lot of services go, no, we can't administer Panadol. If they need Panadol, they need to go home. If they need paracetamol, they're sick and they should be at home. And I'm like, well, actually, you can't be that black and white, because for some families, managing that pain, if you can't manage that pain at the service, that child's never going to attend anyway. So I think having black and white rules in your head about what you can administer, what you can't, is not the right way to approach it. You need to be aware that there are nuance in all of those things. So I think those might be things. The parents are your really biggest resource. Ask lots of questions. Get medical plans in place. Don't be afraid to ask for medical plans. And just be aware that things are not black and white, and that you need to be able to see the nuance and the differences that might occur for other families. So, yeah.
Sounds like brilliant advice to me. Thank you very, very much.
My pleasure.
Okay, thank you.
Okay, what a fantastic interview. So I hope that provides you with lots of clarity about the difference between disabilities and medical conditions. And it was such a good insight into managing medical conditions in a family daycare setting. So a big thank you to Kylie Purdie for all that insight and sharing that knowledge. Okay, so why do we need to be equipped to deal with medical conditions in family daycare? Now, we all know as educators that children's health and physical well-being contribute to their ability to concentrate, cooperate, and learn. So being active, healthy, well-rested, and free of illness assists children to participate happily and successfully in the learning environment. Now, all educators and care services must have systems in place to manage children's diagnosed medical conditions. Because family daycare educators work independently, it's even more important that we think through the possible situations that might occur when we're caring for children with a diagnosed medical condition, and have plans in place to minimise risk and to act in a medical emergency if a medical emergency does occur. Having planned and thought in advance means that we are more likely to know what to do if we are faced with a medical emergency. So just as we plan for children's safety by doing things like risk assessments and installing safety gates, we need to plan for children's health by having in place medical management plans and risk reduction strategies when children have specific medical conditions. Now, we're very lucky that we rarely have deaths of children in education and care services in Australia, but it has happened. And one of the reasons we have so few compared to countries like America is because we have our ECEC regulations in place that demand we take special care, that all our educators have mandatory first aid training and anaphylaxis and asthma management training. So it's because we are so heavily regulated that we are able to say we have very rarely do we have deaths in early childhood education and care centre settings. So how do we prepare as a family daycare educator once we know that we have a child with a specified medical condition? So there's 9 specific things that we need to do, and I'm going to go through these with you now. So the first thing we need to do is we need to make sure that our training is up to date. So our first aid course has to be approved. Each family daycare educator and family daycare educator assistant must hold a current approved first aid qualification. They must have undertaken current approved anaphylaxis management training, as well as currently approved emergency asthma management training. So you must have those 3. Each family daycare educator and educator assistant must hold all 3 qualifications. And we need to renew our first aid training every 3 years and do a refresher in CPR every year. So your certificate will state the date on which you completed the course, and it may also include information about the expiry date or requirements for refresher training. So you can check in with that on your statement of attainment. Managing medical conditions policy. We need to understand and follow our services medical conditions policy. And we spoke about educators, the need for them to know their services medical conditions policy. So it's really important. Managing medical conditions policies tend to be one of the bigger policies because they have to cover a lot of things, such as how to administer medicine to a child, which we know can be a bit of a process. And it's worth reading this each year. And if there's anything you don't understand or you feel that needs updating or, you've got feedback on, please talk to your service about it. But you really should be nice and familiar with your medical conditions policy. Now, the third thing is we need to follow the regulations. So the regulations require different things of the service we're registered with, and then us as educators. So the service has its responsibilities, and then us as individual educators have our responsibilities. So the regulations require our family daycare service to make sure that every reasonable precaution is taken to protect children from harm or hazards that could cause an injury while they're with you. And that's in section 167. The service needs to have procedures if a child is injured, becomes ill, or suffers a trauma, and that's regulation 85. The service needs to make sure that a parent or a child you care for is notified as soon as possible if the child is involved in any incident, injury, trauma, or illness, and that's regulation 86. So as I go through these regulations, it's probably a really good idea to check in and make sure that you feel that your practice as an educator is compliant and making sure that you're meeting all of these. So the next one is make sure you have a first aid kit, and that relates to regulation 89. Have a medical conditions policy that covers what is required when a child is enrolled at the service with a specific healthcare need, allergy, or relevant medical condition, and that's regulation 90. Make sure parents have a copy of this policy, that's on regulation 91. Make sure that a medication record is kept of when medication is given to a child in your care. So any medication given must be documented, and that's in accordance with regulation 92. Make sure you only give medication to a child if it has been authorised by the child's family and given properly, and that relates to regulations 93, 95, and 96. Next, make sure you have a current first aid qualification and have done anaphylaxis and emergency asthma management training, which we spoke about, and that relates to regulation 136. Collect health information in the enrolment record of every child you care for, including specific healthcare needs and medical management and risk management plans, and that's regulation 162. Have a medical conditions policy, regulation 168. And finally, must take responsible steps to make sure you follow this policy. So it's not enough just to have a policy. You need to make sure you're doing everything you can to follow all the steps within that policy. Okay, so that was a lot of regulations. So under the regulations, we then have what the educator is responsible for as an individual rather than the service. So a family daycare educator must keep an incident, injury, trauma, and illness record, and that's regulation 87. You must have a suitable first aid kit, regulation 89. Keep a medication record at any time you give medication to a child. Make sure you only give medication to a child, again, that's been authorised by a family and given properly. So making sure that you're following the dosage, checking the expiry date, making sure that it is for the child's name. So something that can often happen if there's siblings, mum and dad may, or the carer may exchange medications between children. So making sure it's the child's name on the label. And make sure we have every child's enrolment record. because enrolment records can provide some important information that we can cross-reference with things like medication and medical plans. And that's Regulation 160. So I hope that gives you a bit of an overview of compliance as an educator, but also for your service as a whole, and checking in and making sure you're meeting all of those. Okay, so the fourth thing we need to do, services have to have a medical conditions policy, even if there is no child with a medical condition enrolled at the time. And this is because circumstances could change or new medical conditions can emerge and new children enroll. So rather than being reactive to that, we really want to be proactive. So that's why it's really important that we have that policy ready to go. So that at any stage, if an existing child develops something, or if we have a new child come and enroll. So making sure you have that policy ready to go. And it's also good that you yourself as the educator know what to expect and you understand what your duty of care is in relation to that policy. Now, without alarming you too much, a child could have their first anaphylactic attack or their first asthma attack while in your care. So being prepared will help us be calm if something does happen. So this could be that if a child hasn't actually been diagnosed as anaphylactic or asthmatic yet, because we are dealing with that young age group, 0 to 5. So it is quite possible that they will have that first occurrence in your care and they don't have the required medication or the required medical plan. So really important that we can be calm and be prepared if that does happen. Okay, the next thing we need to do is plan. So plan to reduce the risk for the child, plan to deal with their medical condition, and plan to communicate about their medical condition. And the first plan we need is a risk management plan. Now, a risk management plan is all about prevention. The plan is about what you will do to prevent the child becoming sick while in your care. So as you complete a risk management plan with a family, you need to work out what the risks are to the child's health in your family daycare and how to manage those risks and try to make sure that they're reduced. So a risk management plan needs to have in it an assessment of the specific risks there are for the child's health needs, any allergy or medical condition while in your care, and you need to know what you're going to do to reduce the risk. So any requirements for safe handling, preparing or eating food if relevant to the child's medical condition, how you will let other families know about allergens that pose a risk to the children in your care, if this is relevant to this child, how you will make sure other people that may meet the child, so for example, coordinators from your service or other educator assistants, you can identify the child and their medication. So you also have to display a poster saying that a child at risk of anaphylaxis is attending your family daycare. So that needs to be displayed so that any visitors or anyone else coming into your service is made aware. And any overall risk reduction strategies you have taken. So for example, declaring your home is a nut-free home if that's what you choose to do. So any child that has a diagnosed medical condition must have a risk management plan developed by your family daycare service, as well as developed by us as an educator and the family. So the service, the educator and the family should all be working on that collaboratively. It's also important for us to do wider risk management plans for common medical conditions such as allergies and asthma, because we should try and reduce exposure to things that may cause food allergies and asthma in our service. So at assessment and rating, the officer could ask to see those plans. So make sure that you have them ready and available. We also need to include in our risk management plan for children with specific medical conditions how we're going to manage the risk when we take them out of our service. So for excursions, for example, so a risk assessment is about thinking of the worst things that could happen and then working out how to stop them from happening. So you're probably used to doing risk management for excursions by now, and a risk management for a medical condition is similar, but it's specifically about reducing the risk for that child. So let's look at an example. So say, for example, we have a child who has asthma, and one of their main triggers is dog hair. So a risk reduction strategy we could have is making our service dog free. But how else could the child come into contact with dog hair in our service? So what about if a child came into our house and they have a dog at home and they have dog hair all over their clothing? How can we manage that risk? How can you manage the risk to them meeting a dog on an excursion is another thing to think about if you're doing excursions. So risk reduction is complex and it needs you to think through lots of worst case scenarios and then address how you might either reduce that risk or eliminate it altogether. Okay, so medical management plan. So medical management plan for a child with a medical condition must come from their doctor. And it needs to tell us what we should do if a child with a medical condition gets sick, what we do when a child has an anaphylactic attack, what we do if they develop asthma, and what we do if they go hyper or hypoglycemic. So what the difference between the two are. So hypo is low blood sugar and hyper is high blood sugar. So we need to be aware of those. And a medical management plan should leave us in no doubt as to what we need to do and when we need to do it. So what medication to give and when to call an ambulance. So very clear step-by-step instructions that are easy to follow, because as you can imagine, you may be slightly panicked or anxious in that situation. So those medical management plans need to be simple, clear instructions on what to do. The last plan we need is a communications plan. So children with medical conditions need medical conditions change continually. So the communications plan ensures that we're always in the loop. The communication plan will usually tell us how information will come to us about the child's medical condition and what needs to be done to keep them safe. Generally, the family would talk about our family daycare service, to our family daycare service and to us, but the plan needs to make this clear. It'll also clarify how we will be updated about any changes to the child's medical condition or treatment, and how we will update the family and our service about the child's health. Okay, so number 6, we need to actually implement the medical management plan if there is an emergency. So have you ever heard the expression running around like a headless chook? So it means not knowing what to do, running around aimlessly, especially when there's an emergency. And as I mentioned before, it does happen. You can feel panicked, you want to do the best by the child, and you want to resolve the issue as quickly as possible. So following the medical management plan stops you running around like a headless chook. Now, in a crisis, your brain is going to want to make decisions and not always the best one. So the good news is there are steps you can take to be a better decision maker in emergencies. There is science behind the way people react to stressful situations, and we can use it to our advantage. So science tells us that people behave in high stress incidents in certain ways. So what you do will depend in a large part on what your stress level is. So if your heart rate gets too elevated, you're more likely to go into shutdown mode and not be able to think clearly or act. During the decision-making process, your mind will most likely move through the 3 stages. The first one is denial. The second one is deliberation. And the third one is decisive action. So knowing these stages and preparing for them ahead of time can help you recognize and deal with what's going on around you more effectively. So before you take action, calm yourself. Now is the time to put your plans into motion, give the medication, call the ambulance, follow the plan. In most crisis situations, there is no definite right or wrong. There is no perfect way, only the best we can do. So the most important thing is to do something. In almost every case, an imperfect plan is better than no plan, and action is better than inaction. So make sure that you remain calm and you follow the plan. Now, number 7, give medications correctly. Very important. Often children with medical conditions need medications to be given to them. The regulations tell us how and when we can give children medications. So medications can only be given to a child with written authorization from the parent or guardian or a person named in the child's enrollment as an authorized person to give permission. And also it can only be given to a child if the prescribed medication is in its original container with the child's name, the dose, and how often it needs to be taken. Now, when a family wants their child to take medication, they must complete a medication authorization record. Medication must be given directly to us and not left in the child's bag, because the last thing we want is for another child to be able to access that medication and they may accidentally take it, or the child themselves may try and administer themselves. So all medication, of course, needs to be kept out of reach of children, and we need to store the medication in a designated secure place. Remember that an older child in our care, so school age, may be responsible for administering their own medicine. So, for example, having an asthma preventer spray. So how they will do this and where their spray will be kept while they're with you needs to be clearly outlined in our services dealing with medical conditions policy. And they'll need to be authorized by the family to do this. So they'll have permission from the family to medicate themselves, but you need to have that mentioned in your dealing with medical conditions policy. Okay, checking medication. So before we give a child medication, we need to check that the medication is in its original container. So for example, if a parent brings in some antibiotics, but they've decanted it into a jar for some reason, maybe it was leaking or it had broken, we really don't know, without it being in its original packaging with the original label, what it is in this jar. So it needs to be in its original container and packaging. It has the original label with the child's name on it, so making sure that we're not prescribing someone else's medication, or we're not administering someone else's medication, that it's within its expiry date or use by date, and that we will be giving it in line with how it has been prescribed. So for example, if the label says take 1 tablet 3 times a day, we can't give 2 tablets at lunch. So you need to follow the instructions. Now, once you have administered medication, we must record what medication has been given. And before we give a child medication, we must make sure we record it on a medication chart. So we're recording exactly what has been given at any time. We also, number 8, we also need to keep records about medical conditions. So keeping the right records. And I love this visual because I have often felt like this, working in early childhood, surrounded by paperwork and overwhelming amounts of forms and documentation. So this is great imagery here. I'm sure we've all felt like this sometimes. So incident, injury, trauma, and illness records. Now, this record details every incident, injury, trauma, or illness that occurs in relation to a child while that child is being educated and cared for by an educator. So you must keep it while you are an educator, and it must include circumstances surrounding the injury, the incident, the trauma, or illness, or what happened in the lead up to it, or what were any related factors involved, the details of any action taken by you, including administering medication and medical people, and details of any person who witnessed the incident, because they may need to have a discussion later. So we, or the service we're registered with, we have to keep this until the child is 25 years of age. So really important. Medication records. These records include information on each child who requires medication while at our family daycare, and the record is kept with you, the educator. Medication records must be kept in a safe and secure place until 3 years after the child last attended. So from their last day in your care, 3 years from then. Okay, number 9, remember you may have children of different ages. Children that are school age may be used to giving themselves their own medication, especially asthma preventatives. They may do it themselves with a spacer. How will we manage this? So will they give us their medication when they come to our house so none of the younger children can access it? You really need to think about that, and you really should have it in your policy so it's clear and consistent every time. All of these things need to be considered in our plans and in the service policy. Okay, so allergies and anaphylaxis. We are just going to take a few minutes to look at specifically at allergies and anaphylaxis. So allergic reactions are common in children, and they happen when the immune system reacts to something in the environment that is normally harmless, such as food proteins, pollens, or dust mites. Allergic reactions can be triggered by an allergen, the substance the person is allergic to. So coming in contact with the skin, eyes, nose, lungs, stomach, or bowel. The most common cause of allergies are medications. So for example, antibiotic or anesthetics. Other causes are food or bee or insect bites, so wasps or jack jumper ant. Latex, so from rubber gloves, can also do that. So many allergic reactions are mild, but some can be extremely severe. So anaphylaxis is the most severe form of an allergic reaction, and it's life-threatening. It's estimated that 1 in every 100 school-age children have anaphylaxis. So with planning and training, anaphylaxis can be treated effectively. Now, food allergies in children can be due to peanuts other tree nuts. So you've got Brazil, cashew, hazelnut, almond, fish, shellfish, eggs, wheat, milk products, soy, seed, and some fruits. So they're your most common food allergens. Now, food allergies are more common in children under 5 years of age than in older children, as young children may grow out of food allergies, and we do often see that happening. The most common food allergies are due to milk, egg, and peanut. So peanut allergy is the most likely allergy to cause anaphylaxis. The most severe form of allergic reaction to any substance is anaphylaxis. And this is life-threatening and effective and really requires immediate management, usually through adrenaline. So is a child's food reaction an allergy or an intolerance? Sometimes a food intolerance can be confused with a food allergy because many of the symptoms can be similar. However, intolerance and allergy are not the same thing. Allergies involve the immune system, but intolerance does not. Food intolerance will not lead to anaphylaxis. So an allergic reaction to food can be triggered by even very small amounts. Intolerance is when a person can tolerate a certain amount of food trigger, but when they have had too much, they become unwell. So what are the signs of anaphylaxis? And we need to be really aware of this. Hopefully we all know hopefully we all know this from our anaphylaxis management training, but let's go through it anyway, because it's always a good idea to have a refresh. So mild to moderate allergic reaction. An allergic reaction will include one or more of the symptoms, and it is possible that a number of them will happen at the same time. So we've got hives, welts, or like a red lumpy rash, a tingly feeling around the mouth, stomach pain, vomiting, and diarrhea. Facial swelling can also be a telltale sign. So the first time a child has an allergic reaction, they should go to a doctor, and the doctor will confirm whether the child has an allergic reaction and advise how to treat the reaction next time it happens. They may be referred to an allergy specialist. So be aware that occasionally a more severe reaction may occur when a child is exposed to the allergen for a second time. Severe allergic reaction, so anaphylaxis. A severe allergic reaction involves a person's breathing and or circulation, so their heart and their blood pressure. At least one of the following symptoms indicates a child is having an anaphylactic reaction. And the symptoms of a mild to moderate reaction that I outlined before may or may not be present. So for anaphylaxis, we're looking at difficulty with breathing and noisy breathing, wheeze or persistent cough, swelling to the tongue, swelling and tightness in the throat, difficulty talking or a hoarse voice, persistent dizziness, or they may collapse, and they may become pale and floppy, especially in infants and young children. That's something to look out for. Just note that stomach pain and vomiting alone are not are signs of anaphylaxis after an insect bite. So if you do have a child with stomach pain and vomiting, just have a think about if they may have been exposed to an insect bite. Okay, so how are we going to treat anaphylaxis? So the first line treatment for anaphylaxis is adrenaline. You may be familiar with the EpiPens on the screen there, and it is given in the form of an injection. So if a child has an anaphylactic reaction, follow their plan or do the following. Have the child lie down, but if breathing is difficult, you can allow them to sit up. You want to inject the child with the auto-injector and call an ambulance immediately. And a second auto-injector is sometimes needed while waiting for an ambulance. So if it is an extended amount of time, they may advise you to administer a second one. So with auto-injectors, a few things to note. The most common auto-injectors in Australia are EpiPens, and we do have EpiPen Junior, and we also have Anapen and Anapen Junior. So you and the child, if they're old enough, will need to learn how to use their auto-injector and keep a copy of the child's anaphylaxis action plan with the auto-injector. So make sure it's stored in an insulated container, clearly labeled with the child's name. And you can always get the family and parents to give you a bit of a demonstration, obviously a mock demonstration of what you need to do and how to use it. And you'll find too that there are very clear picture instructions on the packaging. You need to store it at room temperature in a safe, easily accessible central location. When you're out of the house, the child's injector and action plan should be carried with them at all times. So regularly check the expiry date and ensure the window is clear on the auto injector. So it has a little window so that you can see that the adrenaline inside needs to be clear. If it's cloudy or if it's gone off color, let the parents know straight away, as you may need a new pen. Okay, and keeping in mind your family daycare service will have policies in place to prevent reactions in children at risk of anaphylaxis. So have a think, are you nut-free? Are you always nut-free, or only when you have children with anaphylaxis? And they're things that you need to really consider and decide as an educator. So one of the great things about family daycare is that we have direct and frequent communication with a child's family. And this makes it easier to manage a child's medical condition. So hopefully not feeling too overwhelmed with all of this fantastic information tonight, but it's really there to support you in managing these medical conditions, and believe that you've got this as a fantastic educator. Okay, so we do have 2 more videos for this evening. The other, our wonderful Lisa Bryant, our journalist, is interviewing tonight 2 educators, an educator and a family daycare coordinator who have done a lot of work with children with medical conditions. So lots of first-hand knowledge and experience here. Now, the videos run for about 13 minutes each. And then, as I mentioned, as always, we'll have plenty of time for questions. So these videos are on the PD in Your Pocket webpage if you would like to view them again later.
Hello and welcome to our first interview of the evening. We're having 3 tonight, so that'll be really fun. Our first one is with Carol Booth. Hi, Carol.
Hi, Lisa. How are you?
I'm good. Now, you've been connected with family daycare for years. Tell us a bit about your background and about what you're doing now.
I started family daycare actually because some of my friends were doing family daycare, and the other work that I had been doing had ended. My own children had finished school and were starting university, and it was at one point all 3 of us were sort of studying at the same time, which was fun. And I found the more I did, the more I just really thought it was super valuable. And so starting really to spend more time with friends who were working became something that was less of an issue. It was more about the work, and I just finished my Cert 3, finished my diploma, did my advanced diploma in community sector management. I've done the Early Childhood Australia Leadership course. I just like finding out more and more about how to do this better.
And you've stopped being an actual educator now, haven't you?
I have, yeah. So 2013, I was offered the chance to do part-time coordinator and part-time educator when I moved to Melbourne. And I really loved the balance of the 2 because I got to see the policies and all that stuff that you sit behind the desk brainstorming actually occurring when I'd go on visits to the children, but also on my days as an educator, I was living those sorts of things as well. So I found it made it seem a lot more real. And I found that my decision making back in those days, and also now, but having that educator experience gave me sort of more empathy when creating policies, making them a bit more realistic and achievable for educators.
And you're a full-time coordinator at the moment, yeah?
No, I work part-time as a mentor and also as the policy and advocacy leader for Inspired EC.
Right, okay. So tell me, in all of that background, have you ever had to deal with children with medical emergencies?
Medical emergencies, yes. You sort of average
medical conditions, let's say.
I find a lot of children who come to family daycare do have medical conditions. I think the parents are seeking a service that they talk to the same person at the beginning of the day and the end of the day. So family daycare seems to attract them, and also the smaller ratio that we have in family daycare. I think, as the children get older, sort of from 2 and 3, it's easier for the family to sort of manage the child's medical condition in collaboration with the educator if the child is part of a smaller group. And yes, I have had,
I can imagine. Yeah,
quite a few children that have had the asthma and all those sorts of things, you know.
So give me some names of conditions of children.
Well, asthma seems to be a big one, especially down in Melbourne. Celiac disease, dairy intolerance. I haven't had anyone with diabetes, but as a coordinator, I've had an educator who had a child with diabetes who needed injectables. That required extra first aid because the first aid that educators must have isn't comprehensive enough for diabetes. So there was a lot of, we seem to just have a variety of things. And the children who have a medical condition, if it's managed well between the educator and the family, we tend to not have too many flare-ups.
And if, have you or have any of your educators ever had to deal with a medical emergency?
I've had a couple with a child spiking a very high temperature, a child who couldn't have paracetamol or ibuprofen. So that was really getting into a shallow sort of body temperature bath and just trying to cool the child down while balancing a phone, trying to call the parent at the same time. Fortunately, there was someone home and they only lived a couple of streets away. Other times, the child who had an asthma plan, we'd followed the asthma plan, they'd had their medication, they weren't improving, so phoned the parent and they went to the doctor. Things like that. I haven't had any ring 000 episodes, which I'm very grateful for.
And do you think that's unusual, or do you think most educators would never have to get to a stage where they call 000?
I think the second one, and I think that's because we get to know our children so well in family daycare, and you get to sort of, you can really pinpoint those little clues leading up to the child becoming, having an acute attack of their illness.
Okay, now do you, as a coordinator or mentor, do you work with an educator to draw up risk management plans?
We do. So I find Regulation 90 and 91 has heaps of good information, as does the guide to the NQF, of what is expected when a family enrolls a child, and what the service has to do in conjunction with the educator, working with the family to draw up those risk minimisation plans and communication plans, and getting that medical condition management plan from the family at enrolment time as well.
And when you're doing a risk management plan, do you kind of go, okay, imagine the craziest possible thing that could happen? Like, how do you envisage things that haven't actually happened?
You have a conversation with the educator, and it also comes back to knowing the type of activities that they do in their educational plan and their environment. And so you know that, say, if this child has asthma and they're allergic to, say, grass pollen, and this educator likes to go on bushwalks, well, you'd sort of have that as part of your risk minimisation plan. What would you do for that child so they can still be included in the activity? So it might be a case of you always take the medication when you go on an excursion, but you might wash their face and change their clothes when they come home so that they're not having the pollen that they've collected on that bushwalk later sort of breathed in and causing an issue. Things like that we sort of run through. Cooking activities. If you've got a child who's got an egg intolerance, you would talk about the menu that the educator provides or the type of food that the families send as well. And you'd display a sign in the area where the children are for all of the families to see that there is a child in the service who has, anaphylaxis to egg or whatever it is. And, you'd ask the other families to resist sending those sorts of foods to childcare. They would have them at home instead.
And do obviously, are there some educators that you deal with that you think, look, if there was an emergency, this person would be really calm and really, chill about it, or others that you go, oh, I'd hate, I'm not quite so sure if they'd manage an emergency as well as someone else?
I think I'd like to think that all of ours would be fine. I think definitely in the past I've had educators when I was at another service who I think it would have really, really bothered them. Also educators that were very good at phoning the office, phoning a colleague, so they would seek support fairly quickly as well. But I'd like to think that all of the educators that we take on are capable, and that comes down to screening your educators through your interview process. Because you do anticipate.
I sometimes wonder I wonder sometimes how I'd go in an emergency. Like when I think about how I've done it in my life, sometimes I'm really good, and other times I'm just like, I could do things a lot better than what I have.
I think when it's not your own children, you've got that tiny little bit of sort of sideways removal of emotions and your training kicks in. Yeah, it is a little bit different than looking after your own kids when something happens, because you've got that sort of parent thing happening and you're starting to panic and anticipate everything. But when it's family daycare children, I think it is easier to sort of stay calm, stay level-headed, and you talk to the children and, mum, dad, grandma, whoever their grown-up is that's coming to get them, they'll be here soon, we're going to be fine, I'm here, I'm looking after you.
Okay, so what advice would you give educators, who might be thinking of enrolling a child with a medical condition?
The parents are a fantastic source of information because they've been managing the child's medical condition, if it's already diagnosed, up to the point that the children start with you. And they're a really good source of information for all those little kind of nuanced indicators which are not in a medical list of symptoms. So say, for instance, a child who gets chronic earache and tonsillitis, one of the things I'd noticed with that child was they wouldn't want to pick toys up. They wouldn't want to kneel on the floor and lean over and play with train sets that day. They would stand up. They do a lot of standing up sort of play because obviously putting their head down was uncomfortable for them. So for a child, when you know that they've got that sort of medical issue and you notice that, you think, I might watch them really close and we'll see what happens. And half the time, if you mention it to the parents, I noticed this today, that night you'll get a phone call from a parent saying, yep, we've got an ear infection, we've spiked a temperature, thank you for telling me that. So, yeah, it's about knowing your children really well, good sort of communication with the families, and jotting down a lot of little notes. Sometimes it's the little diary jottings that we do that piece together a much bigger picture to help a child get that diagnosis further down the track, because not all children come to us with that medical condition diagnosed. A lot of the time the educators are part of that diagnosis process, and it's our observations and our notes that sort of contribute to all of that too.
I think that's one of the most important things that you mentioned, that we do know our children so well in family daycare that it really, it does really make it a lot easier to notice small signs. Well,
Yes.
Thank you very much for talking to us tonight. I really appreciate it. And I'm
That's
sure
my pleasure.
out of it. Okay.
Thank you, Lisa.
Bye.
Bye-bye.
So I'm really pleased to have with me Kayleen Milligan. Kayleen's also a family daycare educator. Hi, Kayleen. How are you?
Very well, thanks, Lisa. Thanks for having me.
Oh, thanks for doing it. How long have you been an educator for?
I've been an educator for 22 years. First 5 years I was an in-home carer, and then the last 17 years I've been a family daycare educator.
That's a long time, eh?
Yeah, not wrong.
Where are you based?
I'm based in Kempsey on the Mid-North Coast, and I'm registered with Mid-Coast Family Daycare.
Cool. And have you had many children with medical conditions during that long and illustrious career?
Yeah, I've had quite a few. We've had anaphylaxis, we've got egg allergies, we've got restrictive airways, which seems to be a new one just at the moment. And I also have a child with FPIES.
Oh, okay. Now, there's two conditions I hadn't heard about. Tell me about restrictive airways and then tell me about FPIES.
Restrictive airways, I think, is a doctor's way of saying it could be asthma, but we can't diagnose it yet until you reach the age of 6. So they call it restrictive airways or preschool wheeze, something along those lines. Really nothing to worry about. You know, children don't have preventers or anything like that to be used in care. It's just something that the doctors are calling it until they can diagnose a proper diagnosis.
So do you have a specific medical, plan for a child with that kind of nebulous sort of medical condition?
No, there's they have no preventatives or anything like that. All I can do is if I notice the child's struggling with their breathing or anything like that, is to sit them down, calm them down, and just call mum.
Fair enough.
Yep.
Okay, and what about FPIES? What's that?
Well, FPIES, that's sorry, just to look at my notes here to give you the full name of it. FPIES is a food protein induced enterocolitis syndrome. Very rare, apparently.
Is that the one I've heard of people being like allergic to meat?
No, it's protein allergy. It's mostly found, I think, from the little bit of research I've done, the triggers are like dairy or soy, or sometimes you might get your oats, your barley, things like that. But the particular child that I have, her trigger is cashews. So
Right.
It's not anaphylaxis, which we know is immediate, closing of the airways and all that. This one FPIES is to do with your small and large intestine, and it can happen instantly, maybe, or anywhere up to 2 hours later. And what its triggers are, it's profuse vomiting and diarrhea. So you could think it's a stomach bug, which most places, I think, with the child in question, when she presented at the ER first few times, I think they thought it was a stomach bug. But the last one that the last attack, which thankfully hasn't happened for a couple of years and has never been while she's been in care, was very serious, that she was lights and sirens to the hospital, and she actually stopped breathing on her way to the hospital. So should she have an attack while she's in care, there's nothing really I can do except make her comfortable, because there's no EpiPen, there's no medication or anything that I can actually give her to help her. All I can do is make her comfortable, call an ambulance, notify the parents, and send her, which plan is it? Her action plan, a copy of her action plan with the AMBOs, because on the bottom of the action plan, the doctor has actually written a note for the ER department as to what medication to give her to help her when she presents at the hospital.
So in a situation like that, sorry, it's something I'd never thought before, you couldn't actually go with the child in the ambulance because you've got other children.
That's right, yeah.
So what have you ever had to call an ambulance for a child?
No, thankfully not. This particular child has other dietary issues as well. So she's gluten-free, dairy-free, preservative-free, also nut-free now, and everything. So we don't really how can I say? If I had to call an ambulance, yes, but I'd also call mum. And given where I live and the distance for the ambulance, I think both would arrive at the same time, a parent or the ambulance and everything like that. So they wouldn't be too far apart that mum would be able to go or dad
with the child.
With them.
Yep.
Yeah.
Okay.
Yep.
And do you are you always nut free, or are you only nut free?
Yes and no. Many years ago when I had the anaphylactic child, yes, I was nut free because he obviously was nuts, and he was very serious that you couldn't actually have had any nut product at home and then come into care and brushed against him, be it on your hands or whatever, because that would cause a reaction. So we made it nut free. He was diagnosed at about 16 months of age. He's now 13 and has completely outgrown his allergy and never
that's great, isn't it?
Never once did we need in care or outside of care need to use an EpiPen for him. He always had one, but we never ever had to use it. And I remember that mum, when she came and told me that he was anaphylactic, and she said, I totally understand if you don't want to care for him anymore. She said it's a big thing.
No.
And I have to say it was a big thing for me too, because I'd never had a child with such a serious illness in care. But I took it on the chin and researched and did as much as I could to help him. And the children in care and the parents were really good. They never sent any nut products. I remember one day we had a child get out of bar. I think they were both 4 at the time. And the anaphylactic boy said, you can't eat that in front of me or around me because that will make me sick. And I corrected and acknowledged and everything like that. And thankfully, the other child complied and he put it away in his lunchbox. But
that's great.
The anaphylactic child was going home in half an hour, and I just said to him, look, if you can wait half an hour for when he's gone home, you can have your bar after the time. So that got around that. The FPIES child, she's now 4. She's been diagnosed probably in the last 2 years with it. Very hard, first off, to get her not to want to graze other people's plates, because they sneak that biscuit off the plate or whatever when you're not looking. But she's now to the stage that if someone pulls out I think nuts, I had a child the other day come with cashews, first time ever mum has ever sent them, and she just said, I can't eat those, they'll make me sick. And in saying that, I didn't ask the child to put the cashews away, because I'd not long read, probably in the week beforehand, that we should encourage children to take responsibility for their illness, allergies, whatever, and understand that not everybody has those allergies, and that it's all right for somebody to have it around me. I just know I can't eat it. And and the little one, she had a few of the nuts, and then she said, I'll put them away, seeing that you're not supposed to have them, and she put them away.
That's great. And what advice would you give to other educators? I think you said that you've kind of become a bit of the go-to educator for people with medical conditions.
To get a lot of children with allergies. I have another one with an egg allergy as well. And it appears that his sibling is also going to be egg allergy as well. So when he comes into care, I think basically the advice I'd give to educators is work with your parents. Find out, like, we still do cooking activities. We still have our massive big Christmas party every year, where I provide the food. And if you work with the parent and get an understanding of what you can and can't have. So if I've got the child, for example, who has an egg allergy, I've worked with mum and we've got some recipes that we can use so that on those days we do those cooking activities, they're egg free. That way the child gets to eat as well. His birthday, when it comes round, again, work with the parent. We either use an egg free recipe or we'll do an ice cream cake. Whatever works for the parent. Christmas time, you know, with the gluten free, dairy free, preservative free and everything like that, and the F pies with the child, I again work with the parent. And if I'm not sure on something, I'll send her a picture and say, look, you know, because the mum also has allergies as well. So, you know, you're not just catering for the children at something, you're catering for the adults as well. So I'll say, you know, can you all eat this? And what I did last year, because it was really, really hard, we had photos of the children that had allergies and everything, and the food that they were able to eat was labelled with their pictures so that they know they could go to the table and wherever their picture was on the food on the table, that food was safe for them to eat.
That's a brilliant idea.
Yeah, and we talked about it in the lead up to it, and I'd had the pictures already done so that they knew what pictures to look for and everything. But I think just basically just work with your parents. Don't think it's like a life sentence, is probably not the word, but a life sentence of having a child with a medical condition, because you can work around it. Yes, you know, unfortunately, I'm sure sometimes it does happen that, you know, you do end up with that medical emergency. But if you've done your training, you've kept up to date, consulted with the parents, you know what to do. You know, you've got all your medical
good to me.
You know, you've got your medical minimisation plans in place, and you've got your action plans. You know, if you follow those, you know, you're right. And like I say, in all the years I've had kids with allergies, I've not had had to call an ambulance or even send a child home that's sick from something that they shouldn't have had. Yeah.
Okay, thank you very much, Kayleen, for sharing your knowledge with us, and
Thank you.
I'm sure everyone will appreciate it.
Thanks, Lisa. Thank you very much.
Okay, bye-bye.
Bye-bye.
Okay, another great couple of interviews from Lisa there. That was really fantastic and lots of good ideas and insights. So thank you so much for that. I hope you enjoyed them and I hope you found them beneficial. Okay, so before we finish up tonight, we do have some time for questions, and I have been monitoring them coming into the question and answer box. So the first one, it's actually not a question, but someone shared how they currently manage anaphylaxis in their service as a family daycare educator. And I just wanted to share it with you because it's really nice to get insight from other educators about what other people are doing. So this educator said that they have an egg anaphylactic child in their service, but their home isn't nut or egg free. So they put more hygiene protocols in at the entranceway. They clean children at the table, and they include including their clothes if necessary. And their family are not to cook eggs or use peanut paste during family daycare educator hours. And they've reported that in the last 12 months, there hasn't been any anaphylactic episodes. So really good to see how other people are managing and what they do. A question that did come through, do you need to we were talking about that we need to display posters around our service if we do have a child that's anaphylactic, and someone asked, do we need to put what the child is anaphylactic to? And I'd say definitely yes, because the whole purpose of that poster is to make sure that any visitors, so families, educator, assistants, visitors, anyone coming in is aware that you have a child that is allergic to whatever it is, so peanuts, eggs, whatever, and that you're notifying them of that, so that they're a bit more mindful. So they think, oh gosh, I've just eaten some peanut butter toast in the car, I might go and, you know, wash my hands and face before I enter the service. So definitely including what the anaphylaxis is. Another question, someone said they understand that first aid qualifications need to be renewed every 3 years, and the educators can't work without that. Is it the same for that CPR element, the HLT A009? That's the one that needs to get renewed every 12 months. Same again, I wouldn't be letting that lapse. That would relate back to the regulations and compliance. So making sure that neither of those, your CPR component every 12 months or the full first aid certificate, that they're not going past their expiry date. It's really important as an educator. Another great question we had was, what needs to be inside a first aid kit? And now this is really a great question. And New South Wales Family Daycare Association is actually actively getting information from the department or requesting the department, because the regulations aren't very prescriptive about exactly what needs to be included. You know, the numbers of particular bandages and things. And with the amount of regulation that we have to work with, it would be good to have some further guidance as to exactly what needs to be included in relation to quantities and also the different first aid equipment and things in those first aid kits. So we are actively getting information about that. The association is. So as soon as we have some clarity around that, we'll certainly share that with all of our PD Pocket followers. Another question that came through: do you need a medical risk management plan even if you don't have a child in care with a medical condition? So I did speak about this before, that we really want to be proactive with managing medical conditions. So definitely we need to have that risk management plan in place, especially on those broader issues like asthma and anaphylaxis, so that we're prepared, and that as an educator we know, okay, if I enroll someone tomorrow, or if tomorrow someone's parent comes in and say, well, Johnny has developed anaphylaxis, or he's been diagnosed with something, a medical condition, that we already have a plan in place of how we as a service or as an educator are going to manage and respond to that. So definitely, even if you don't have anyone enrolled now, we really want to be proactive about that and know how we're going to respond. Okay. Another question that's come through, do I call in the ambulance or the parents first if the child is having an asthma or allergic reaction? So probably anaphylaxis there. So great question, and really we need to address the medical emergency first. So I would be calling the ambulance first. In your enrolment forms or even in your medical the medical management plans, you would have already had permission to call an ambulance. But of course, any medical emergency, we need to address that first. So I would be calling the ambulance, and then as soon as the ambulance is on the way and we're managing that emergency, then of course, yes, we can inform the parents and call them. Another question that's come through: should we have gluten-free or lactose-free or egg-free food during children's Christmas parties? So I guess that's relating back to if you are doing some entertaining or a special event. And the educator in that interview, you know, she spoke about having special foods for birthdays and things. Obviously, as educators, we know we want to be really inclusive as much as possible. So if there is something that you can do, I think you mentioned working around things like having an ice cream cake, which will eliminate a lot of allergens for children. You know, if there's something you can do that will make every child feel included, then definitely you should work towards that. But I guess the expectation is, it was also mentioned that we do have to accept that some children can't eat certain foods and other children can, and that's going to be a part of life, and they need to be aware of that. But what we don't want to do is we don't want to add any additional risk to the children in our care. So, eliminating that as much as possible, and as much as possible, making sure that all children feel included. So if there's a way that you can have an egg-free cake, for example, so that the child who's anaphylactic to egg can be included in that party and feel like everyone else and enjoy that cake with their friends, then of course that's what we would want to achieve there. Okay, I'm just seeing if we have any other questions. Okay, so someone else has asked, and I do hear educators ask this quite often, should we have a spare EpiPen handy if a child in care has no allergies? But obviously we did discuss about how children can have their first episode in your care, which can sound quite frightening. So you can have an EpiPen on hand, but you really need to think about outside of that emergency, would you be able to, can you administer that medication without a medication plan? And would you be able to diagnose that yourself and identify that, yes, this is definitely an anaphylactic reaction, and that child needs that EpiPen. So you have to really think about what repercussions that's going to have, and if you are actually going to be able to utilize it. But there is nothing to say that services need to have their own EpiPens on hand. That's really something that needs to come from the family and be provided. And you need to fill in all the relevant paperwork as well that we discussed. So having that medication form completed before the medication is administered. Okay, so it looks like that's it for questions. So to finish up this evening, I want to thank you all again for participating. Please remember that you can participate in the Facebook group. So if you haven't already joined, please open up Facebook and type in PD in your pocket, and you'll see what a lively community we have of all our PD in your pocket followers. There's some really fantastic posts about what people are doing related to each session. And we really hope that you enjoy that page once you become a part of that community. As I mentioned, we've got 3 more sessions left for the rest of the year that have been funded by the department. So really looking forward to those. And yeah, so thank you everyone for participating or watching or listening to this session. And I really look forward to seeing you for the next one. Thanks everybody, and have a great night.